right, so tonight we're doing something that we've never done before. We've done roundtable discussions in the past where we've always had like two neurologists at the table, or three neurologists at the table, or a neurologist and a nurse practitioner, or something. But tonight we wanted to do something different. This program tonight is called MS Conversations Now. And what is this about? Well, we're going to be having a dialogue, and we're going to have a patient and the doctor. All right? Who's the patient? I'm the patient. Isn't that a great role for me? All right. So, listen, we're going to have a conversation with each other about different topics. And some of these topics, we're going to ask the audience for their opinions to get involved with the conversation. But right now, I just want to introduce our guest. Okay? Dr. Boster is a board-certified neurologist specializing in multiple sclerosis and related CNS inflammatory disorders. He decided to become an MS doctor at the age of 12 as he watched his uncle Mark suffer from the disease in an era before treatment was available. Dr. Boster grew up in Columbus, Ohio, and attended undergraduate at Oberlin College. He earned his MD at University of Cincinnati College of Medicine and completed an internship in internal medicine and residency in neurology in the University of Michigan. He then completed a 2-year fellowship in clinical neuroimmunology at Wayne State University. Since then, Dr. Boster has been intimately involved in the care of people impacted by multiple sclerosis. He is a principal investigator in numerous clinical trials, trained multiple MS doctors and nurse practitioners, published extensively in medical journals. He's lectured to both patients and providers worldwide with a mission to educate, energize, and empower people impacted by MS. He lives in Columbus, Ohio, with his wife, Chrissy, his son, Maxwell, and daughter, Betty May. And let's welcome Dr. Aaron Boster. And by the way, this boot is here. Why? This guy wears boots, right? And I got to put on a boot just to make it look like I'm part of the equation, all right? So I can't do both because I have a busted up left ankle, but I will put on the right one just so we could do this dialogue and it looked like two cowboys up here, all right?
Howdy. Howdy. That was pretty darn good. You must be warmed up. Can we start by thanking Long Haul Paul? Let's give him a round of applause. Yeah, I'd like to. You know, Stuart has introduced me at programs for the last 5 years.
You're in mic.
Can you hear me? Can you hear me to back? And I've never gotten to introduce Stuart. Stuart was looking for education and couldn't find any. And he did something rather remarkable. He created MS Education. If you haven't checked out MS Views and News, you need to do that. It's a repository of the pulse of multiple sclerosis. And I'm really, really proud that I get to be up here with him tonight. So can we give him a round of applause?
I would stand, but I'm having a problem with that, so I'm just going to stay where I am, all right? All right, so Dr. Boster, can you begin with this?
I would love to. Our plan tonight is to have a discussion and smell your food while you eat it. And periodically you might jump in and ask some questions. We have a list of topics here that we hope resonate with things that are relevant to folks in the room, people impacted by MS, care partners and patients alike. Starting off, we're going to talk a little bit about MS progression. Why? Nobody wants to talk about MS progression. It's kind of something that we kind of keep behind and hope and pray that we don't have to discuss. And so that's not what Stuart and I do. Stuart, when you think about progression, when you think about having MS and the risk of progression or experiencing progression, what comes to your mind as someone living with this disease?
That unfortunately I'm going to wind up having to use motorized equipment or assisted devices or whatnot. But going forward, there are a lot of people out there that just don't tell their doctors enough about their disease progression. They're afraid to tell them. They're afraid of what the medicines might do for them, and so they just seem to hold it back. Or they show up month after month at their doctor's appointment, and their doctor's so busy on doing generalized other tests that they never really get to explain to them that they feel like they're doing worse than a year ago.
All too often, during a busy clinic visit where there's a bunch of things to check off and a bunch of things to do, you can have what I sometimes refer to as a cocktail conversation. Do you know what I mean? Hey, how are you doing? You look great.
That's right.
Do you have any questions? Oh, that's super. Do you need any refills? It was great to see you today. And there was no genuine dialogue. One of the things that drives me bonkers sometimes is when a provider asks a question and then doesn't listen for an answer. Show of hands, you ever experienced that? And all too often, it takes a moment for someone to take time to explain how they're actually feeling.
That's right. So, but going forward, how many of you have been involved where you go into your doctor's office and you don't even know really to begin with, what's going on with you, what your symptoms are. Maybe it's taking longer for you to get out of bed in the morning, and you don't know if you're really tired, or if you have kids, if they're doing it to you, or that you just really don't know what to say in the short period of time that you're there. How many can relate to that? Yes, great. I see that.
I think one of the things that I would like to empower people to do is to be their own advocates. So often, we need to bring an advocate with us. I know when I go to the doctor, I want to bring my wife with another set of ears. And then she can correct me when I heard things incorrectly. And we don't all have that opportunity. How do you ensure that you're heard, or that you cover the things that you want to cover, or that you don't freeze up when you're in front of your doc?
So I make lists, okay? And I begin, first off, through our organization, we created a tool called Land of MS, all right? And this is a 2-sheet piece of paper with everything that's wrong with you about multiple sclerosis. You can fill it out, and therefore you can be ready for your doctor's appointment. We encourage a lot of people to do this. Now, me personally, I don't fill out that sheet of paper. Why? I don't know. I mean, we do have thousands of them, but I do write everything out on a piece of paper beginning about 2 weeks prior to my doctor's appointment. I want to make sure that I'm not going to forget anything. And so I write it down, make notes all over the place. And then the night before my appointment, I just combine everything together, and I feel like I know I'm going into my appointment and everything's resolved. And it's not just with my neurologist. I do this with my dentist too. If I got a toothache, I want to remember I had a toothache, what's wrong with that tooth? All right? So, but that's what you should do.
It's a great idea. Let me teach you a pro tip. When you come in to see the doctor and you bring a list, she feels ethically obligated to let you go over the list. And if you say, hey, I brought some questions in, and you start to go down them, you're going to help the provider realize that you've been thinking about what's going on and you're not done yet. It's an excellent pro tip. It doesn't have to be a formal piece of paper, but I love it when patients whip out their list, and then we can spend some time going through each thing. I think it helps keep things organized. I think it helps keep things on task. And it makes sure that if we don't go on a tangent, that you can get through everything you need.
That's right. That's right. Does anybody have some other idea of what you do?
What's a tip from you guys in the audience?
Does anybody have a tip of what you do? Do you record it? Do you put it in your phone? Oh, that's great. So she brings her husband as her backup. So if she forgets something, her husband will hopefully remember. Anybody else?
This is the audience participation portion, where we ask you a question and then someone volunteers. Yeah, there you go.
You have a what? You have a journal. That's great.
Any other ideas? Debrief afterwards. That's a great idea. One of the things that I'm very fond of doing is providing a summary that I'm typing while we're talking, so I can give it to the patient and the family on the way out. This is what we discussed. Here's the changes that we made. Here's the homework that you have. Because I want to be able to summarize, not just for me, but for the family, what it is that we talked about. What's another tip? There are millennials in this room. You don't like to be called millennials, but you are.
I say you drew on a chalkboard or on the board once, and I took pictures of it so I remember later.
Okay, so she drew pictures on the chalk. I mean, her doctor put pictures on the chalkboard just for her to remember. But how did you go to the appointment to remember anything? You come with lists. Anybody else? What do you got in the pink? So this person uses visualization to remember what she's got, and whether it be a hot day or a cloudy day or something, she just relates her MS symptoms to different things that she sees in the environment. Good answer. Anybody else before we move on to the next topic? Yes. You put it on your phone. Great. That's great. Hopefully your battery won't go bad.
Raise your hand if you don't have a cell phone on your person right now. Raise your hand. 2 people, 3 people didn't raise their hand. 5 people didn't raise their hand. The vast majority of you have technology in your pocket where you can take notes and bring it in with you. I think that's an outstanding idea. In the back of the room?
Alexa. Alexa challenges her with her lists.
So, leveraging technology, you can say, hey Alexa, write this down for me. And then you can push it to your phone.
That's right.
One time my kids asked me to spell something and I didn't know, and they said, that's all right. Hey Alexa, how do you spell? Sure. Alexa knew.
All right, next thing. We're going to talk about understanding MS symptoms, all right? There are a lot of patients that just don't understand when they're really having a symptom. There's a lot of people in this world that just, are they tired or are they fatigued? Okay, is the pain in their body something that is cold related, or is it something that is just going on? And how should patients, so my question to you is, what should patients know to understand when they're having a new symptom versus an old symptom, and if they're having a relapse, or is it just an old symptom?
So, as a human being living your life, you don't know if you have a new inflammatory spot in your noggin which is causing a problem, or if you have a urinary tract infection which is not causing burning when you urinate, causing a problem. All you know is you have a problem. And I don't want you to play Dr. Google. I want you to report if you have something new going on. I start most clinic visits after we sit down and get a cup of coffee asking the following question. Since I saw you last, is there anything new? Since I saw you last, is there anything that's old but it's worse? And since I saw you last, has anything gotten better? Now that's a pretty vague question on purpose because it's not my goal that you figure it out. I'm going to help you do that. I just want to start the conversation about a symptom that you might not know how to categorize. And then together as a team, we're going to ferret it out.
What about all the people that, they're not remembering? Is it always MS, or is it stress related? Is it MS? Is it not stress related? And is it not MS? And is it maybe just age related? How do you differentiate, or how does the audience how do they know the difference of when it is actually MS related or if it's something else going on in their life?
So Stuart brings up a really good point. My mentor used to say, Aaron, sometimes nature's too generous and you can have MS and something else. And at the end of the day, you're not multiple sclerosis. You're a human being trying to live your best life. You happen to have MS and you didn't sleep and you're stressed out at home and you got a problem at work and you have a broken foot and so on and so forth. And so in some ways, it almost doesn't matter. It's something you're experiencing. And I view myself as a team member trying to figure out how we can make that better. Now, that being said, we can start to pick it apart. And we can start to ask qualifying questions about when something is happening and how something is happening and what seemed to make it worse and what seemed to make it better. I one time had a patient say, why are you asking me all these damn questions? And I said, because I'm trying to get to the bottom of what's wrong. And sometimes we figure out that the reason that you're exhausted is because you're sleeping 4 hours a night. It's not because of MS, it's because you're exhausted. Sometimes we find out that you're exhausted because I put you on a medicine that's making you really sleepy. I'm sorry. But it's through a conversation that we can sort that out.
That's great. That's great. Anybody here have issues with their cognition that they don't know if it's MS related or something else? Great. Glad to hear that. Glad to see it. Now I know I'm not alone. All right?
I thought it was funny that some of you raised your hand and some of you pointed at your spouse.
Right.
Yeah.
And there was some that didn't want to really raise their hand and they kept it down here. They didn't want to really be recognized, all right?
Stuart, let me ask you, when you're having some cog fog, what's your go-to to try to deal with it? What do you do?
Take a pill. No, I'm joking. Wait, I already heard there's an oil for that.
Yeah.
There's, different people using different essential oils these days, all right? But no, what I do is I break away from what it is that I'm doing. If I'm at home, which is rare, but when I am at home, maybe I'll get down on the floor and I'll play with the dogs or something. I'll just do something different that will make me, get out of the environment that I was in mentally and make a change, all right? And that seems to help a lot.
what do you guys do when you're having some cog fog and you're not exactly sure of what's the problem? How do you reset?
Walk away.
She says that she walks away from what she's doing, not dissimilar to what Stuart said, or she gets on the treadmill. I would get on a treadmill if someone had a gun, but God bless you. Yeah.
How many of you use your phones to play a game during the day if you feel stressed out? All right? You do Scrabble or Word with Friends or this or that or whatever. That's great. So that's another great concept to use, though, to help break the monotony. Next.
Yeah, let's do it.
That's great. Let's talk about brain health, understanding brain health, MS relapse. How many people out there really know when they're experiencing relapse versus when they're, experience same symptoms that they did 3 years ago?
So doctors like definitions, like we're like the ultimate nerds. And so the medical definition of a relapse is very long-winded, and it kind of bothers me, but I'm going to share it real quick because you're stuck listening to me. So when you have a new neurological symptom lasting longer than 24 hours, accompanied by changes on examination, preceded by 30 days of quiescence, in the absence of a fever, that's an attack. And I understood almost none of those words. So when I think of an attack, it's when something bad happens to you, and after a day you can't hide it from your wife, and you have to come clean that you can't see real well out of your right eye. Many of you in the room are shaking your head yes. Yeah. And when you have that new symptom and it lasts longer than a day, I want a phone call. We don't know what it is yet. We don't know if you have a problem with your eye or a problem with your brain. We don't know if you have a urinary tract infection, but something ain't right. And MS symptoms last longer than a day. Show of hands if you've ever heard of the 24-hour rule. The 24-hour rule is a great rule, Stu. If you have a neurological symptom, or if you have a symptom, and you have a chronic condition, you're going to ask yourself a wise man's question. Is this symptom related to the thing I have? So I have MS and my nose is itching. Is the itching nose related to MS? That's a normal question to ask. So you apply the 24-hour rule. How long has it been going on? If you say 3 minutes, I'm not yet concerned. MS attacks are caused by inflammation, like when you bang your elbow and it swells up. So if Stu got mad at me and smacked me in my face and my face got all puffy, tomorrow it's more puffy. It doesn't go away.
You weren't supposed to tell them that.
Yeah. and so inflammation in the brain is just like getting smacked in the face. It lasts longer than a day. So if you have a symptom that's lasting a couple minutes and goes away, I'm not as concerned. I want you to use the 24-hour rule so that you don't drive yourself bonkers with each thing you experience. As I talk to you, the area of my head where I used to have hair, it's itching, right? So if I had MS, I might say, is this related? But it's only gone on since I've been talking, so I'm going to let it go.
But what about all those people that want to call their doctor's office last minute and say, hey, I'm experiencing this, blah, 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 and how do we get them to really understand that it has to last greater than 24 hours?
I think it's an education piece. And I think what's important is that you develop a relationship with your provider, because you might wake up one day and have a new symptom. What are you supposed to do? I like to talk to patients about that before they have those symptoms. If you have something going on, here's our game plan. Here's how I want you to address that. And if your doc's not ponying up that answer, I want you to ask them, hey, if I have a new symptom, how do you want me to get in contact with you?
So there are people that may be experiencing something new for them now, but that new actually existed with them 5 years ago. Does that make it a new symptom again, or is it something that they shouldn't even worry about?
If you have an old symptom, and I'll use optic neuritis as an example. 10 years ago, God forbid, you lost vision in your right eye and it hurt like the dickens when you moved it, and you got some steroids and it got better. And it's been gone for 10 years, and it comes back. If it lasts longer than a day, I want a phone call, right? Because I don't know if it's the reemergence of an old symptom caused by a new attack or there's something else going on. And I need to bring you in the clinic so I can figure it out.
So then what happens? So now they've experienced what you would probably think is a new attack. Do you send them for an MRI?
I don't want to get an MRI. I'm going to save $3,000.
Okay.
I want to take a discussion. I want to talk. And I want to find out and better understand the symptoms. And if I'm going to get a highfalutin test, I'm going to get a urinalysis. I'm going to get a UA. Because the most common pseudo attack is by a urinary tract infection. So if I can talk to you and understand your symptoms and rule out a urinary tract infection, then I'm going to get another real highfalutin test. It's called a light. I shine a light in your eye. And with those tests, I can figure out, is this a new optic neuritis or something else? If you're having new MS symptoms and I can find stuff on exam, I don't need an MRI, I have you. The time I get an MRI is when you're telling me you're doing right as rain and everything's fine, and I want to take a look under the hood to see if there's stuff that we didn't know about. So I don't like to get an MRI then.
All right, so what about the person that was fine walking and now is having problems walking? Do you want to know where if you believe that the person might be experiencing something new, a new spot on the brain or a spot on the spinal cord, are you going to send them for an MRI so you can at least know where it's located?
If someone's having trouble walking, it might be because they hurt their foot. If someone's having trouble walking, it might be because they're absolutely exhausted and they've used up their functional reserve and their old symptoms are coming back out. If someone's having trouble walking, they could have blown out their ACL. If someone's having trouble walking, it could be because they threw a clot in their leg. Or it could be something from MS. And we don't get a rule book when we get our bodies, or at least I never got one. And so I think that we can't jump to a conclusion. When a patient calls me and says, I'm having an attack, what I hear is I'm having new symptoms. And if someone's having trouble walking, I want to bring them in and watch them walk. We can learn a lot from doing that.
So that's great to know. Now, anybody in the audience, do you want to add anything to this discussion? We would love to hear from you. Right here.
So not everything with MS involves physical manifestations. And if you think about MS only causes stuff in the brain. And so she says, well, what if I'm not having a new physical thing? What if it's cognitive or emotional or mental? Well, that's on the table too. And so we are not going to limit ourselves. This is not a disease of walking. This is a disease of living. And we're not going to limit ourselves to only stuff that happens when you're trying to walk. And if you're having a new symptom, you used an example of a panic attack or difficulty with thinking or memory or crushing depression. That's impacting the quality of your life. That's making it hard for you to live your best life. That's on the table for us to discuss. Whether it's caused by an attack and we're ultimately going to treat it with steroids, or whether you're having worsening of baseline depression and we're going to treat it with Prozac, we're going to get to the bottom of it. Because at the end of the day, all we're trying to do is to help you be the most awesome you possible. I don't really care how we get there. I'm not proud. And MS can impact anything in the brain and spinal cord. That's a great comment.
Is the person all the way back there in the black hat?
So she shares that she has a lot of brain volume loss, brain atrophy. So just to get you up to speed, everyone in this room over the age of 18, your brains are shrinking. That's pre-programmed. It's supposed to happen. But in the setting of multiple sclerosis, particularly untreated multiple sclerosis, that can happen upwards of 10 times faster than it's supposed to. And so the question is, in the setting of if I have a brain that's smaller than it's supposed to be, could I have symptoms separate from an attack? And the answer is yes, you can. We started the conversation off, Stu, talking about progression.
Yes.
And we can see progression in brain volume loss and shrinkage. And it doesn't mean that we're done. One of the take-homes from Paul today, just because your bike breaks doesn't mean you're finished. You know, I'm the shepherd of the brain, and it's the only untransplantable organ system. I can't swap it out for another engine. And so we're going to optimize what you have. And we can do that a lot of different ways.
All the way in the back?
So she brings up a most awesome point. She says, if I have trouble walking, you make me go see the physical therapist. Don't you guys love the physical therapist? Aren't they the most caring sadists in the universe? I mean, they're like the most wonderful, mean people you've ever met. And she says, well, wait a second, but if I'm having thinking and memory problems, who's the physical therapist for that? There actually is someone. Speech pathologists are rock stars at rehabbing thinking and memory. Did you know that? Speech pathologists or speech therapists are trained to help us with cognitive rehabilitation. And so if you're having difficulty with thinking and memory, one of the tools that we can use is to send you to a speech pathologist.
How do they remember to go there?
You got to write it down.
Got it.
Yeah.
Question, and lady in red.
Are those like where they, how am I trying to think of this?
I got you.
Yeah.
So,
She forgot where she was.
so she says, I don't always have a classic attack, but I can have fluctuations in my baseline symptoms. And what's up with that? So take a look at this wire on this pole right here. All right? So let's pretend that's your wire that you're using for your Christmas lights around this time of year. All right? And so you set up all your Christmas lights, and you have the wire running across your driveway, and your spouse runs over with their SUV and crushes the cord. Right? But your spouse does what any self-dignified person would do. They don't tell you, they just duck it up. Right? So now that cord does not work at 100%. It works at like 90%, which is good enough to stick it away and not tell anyone. The next year when you get that cord out and you plug in 2 Christmas lights, they work great. And then you plug in 10 more Christmas lights, you overload that circuit and it short circuits and all the lights go out. And then when you unplug 7 or 8 Christmas lights, it goes on again. When you have an MS attack, or when you have a new spot on your brain, that's brain damage. And you can recover from that functionally, but structurally, the tissue is damaged. And fluctuations in your temperature, fluctuations in your rest, fluctuations in how much you had to eat can cause those old symptoms to come back. And you can have old things revisit you. That's multiple sclerosis. And that's actually the underpinnings of a lot of chronic fluctuating symptoms. If you don't understand that, it gets really, really frustrating. Because the doc keeps saying, you're not having an attack. And you keep saying, but I'm having a problem. And you are having a problem. That's not make-believe, that's neuroscience. It's not a classic attack, it's fluctuations in baseline symptoms.
Great. That's fabulous. Now let's talk about something a little bit different, all right? And by the way, thank you for all that, and thank you for whoever's getting involved, all right? Yay, thumbs up, everybody. Communicating with your healthcare team, that's the next topic here, right? And there's a lot of patients that just cannot communicate well. Sometimes they feel that, they can speak with their nurse practitioner better than their doctor. But why is that? And also, how is the patient better able to communicate if they don't bring those lists along? Again, the doctor is ready to just go in there. They want you to do the walking test. They want you to pat your legs, They want you to, do the different things, pull my finger, see the strength test, do other things, and pull the finger. That one's always a funny one, right? But when do they really have time to get in there and say, hey, I don't want you doing all this stuff. I want to tell you. I mean, do you guys ever feel that they're wasting your time when you're in there to see and talk to them about something else? Tell us about it. Tell us about it. Who wants to say first? I see your heads nodding up and down. Tell us, you, lady in white, what do you got there? There's a microphone coming to you.
It is annoying when you know you have a problem right away, but you do have to go through all the neurological testing first. But I mean, that's my biggest thing. I mean, I know it's needed to find out if there is a problem, but it is one of those things when you just want to get to the point.
So, can I teach you a pro tip? Yeah. Start the visit off by saying, I really need to discuss 2 things with you. You tell me when I can talk about them. No, I'm serious. Say, hey, today I have 2 important things I need to talk about. Let me know when I can talk about them. You've set an expectation with your provider that there's some things that you need to bring on the table. And you're allowing them to run the visit the way that it feels good to them. But you're putting out there that needs to be discussed. That way, if you get befuddled as you're in your visit, they already know, oh, there was those things you need to talk about. I have a whiteboard in my room, in part because my memory is not awesome either. And so if we're talking about something and I need to table it, I write it on the whiteboard. That way I can look at it and come back to it.
Those of us who do have kind of that anxiety about, am I taking up too much time? Because 15 minutes at 30 minutes, I can talk to you for an hour.
So she says, I have some anxiety, and I start talking, and then I feel like I'm talking too much, and then I shut up, and I'm worried I'm not talking enough. What's the right amount of time? And I want to reverse the question. It's your brain, and it's your body, right? This is your life that you're trying to live, and the provider is trying to help you out, or at least that's the goal. So I think if there's ever a time in your life when you're allowed to be selfish, It's when you're seeking help to live your best life despite having MS. If I think that the conversation's going left, I'll say something to the effect of, I need to change what we're talking about. Right? It's not because I'm trying to be a jerk. Sometimes you'll even hear me say, stop for a second. I have to ask you a really important yes-no question. And then I'll ask a very, very straightforward question because I'm there with you and I'm trying to pull us back where we're coming from. But I want to empower you. This is it. This is not the doctor's disease. This is your disease. They're going to leave the room and not see you again for 3 or 6 months. You're allowed to be selfish with that time. You've earned that. You've waited for that. It's okay to say, I'm not done yet. I really mean that. And if the doctor has a problem with it, maybe find a different doctor.
Anybody on this side of the room have anything to add? We've only been on this side. We need to get more over here. Anybody? Wait, I see people hiding. No? Okay. All right, back to the other side. Anybody over here?
Can I write on the whiteboard?
Yeah, you can write on the whiteboard.
I think visually, and so sometimes I have to draw a picture of what I'm thinking it is, and so then I can say, okay, see, look at this.
I think that's fair. There's no rules. I think we're just trying to communicate the very best we can. And if drawing a picture helps, I draw a lot of pictures when I'm in clinic. I mean, not like pictures of a happy day. I'm drawing pictures of stuff I'm trying to convey to you. I think that's fair game.
So if patients come into the office and they want to know, who does your office have time, or would your office have time to answer if a patient wants to see a urologist, or they need to see a neuropsychologist, or if they need to see any other type of symptom management doctor? A lot of people go into their offices, go into their neurologist's office, and they're told, we'll get back to you, and then they never hear from them again. All right? Or they try to make a phone call and they try to get in there to say, hey, I think, I need an appointment. Or again, they're making a phone call because they want to be referred somewhere else, or they need a prescription for something. How do people get what they need when they're always being put on hold or not being called back?
So that's really important, and the answer is a very, very special word called advocacy. You need to be an advocate for yourself. Now, sometimes you bring in a heavy hitter in the form of your spouse or your best friend or your auntie or your dad, right? And that's bringing an advocate with you. But I want to remind you, you're your own advocate. And I think it is reasonable to set expectations like I was talking about earlier. You can say, if I have a problem, how do I get a hold of you? What's the procedure? And if that procedure doesn't work out, call them to the table. Many times a patient will see me and start the visit by saying, darn it, Aaron, you told me to call you and you didn't call me back. And we have to address that because I told them that was going to happen and it didn't happen. And we have to discuss that. And that's fair. This is an intimate relationship. Your relationship with your provider is an intimate relationship. All right, we're not just like having coffee and beer. We're trying to game out how to live your best life. And you're allowed to have expectations. So my take home here is be your own advocate. We've talked about several tools. Write it down on a piece of paper and make them look at it. Bring your spouse and have him stand in front of the door and say, we're not done yet, doc. But the point is, you have to talk to your provider about what's the best way of dealing with that, and you have to know the game plan ahead of time. You can't be too selfish. You don't get a second chance to do this, guys. This is it.
Listen, sometimes it really pays off to have a New York state of mind, all right? You got to be an arrogant, you got to be, people don't like you for it, but I guess I'll guarantee that you'll feel better for yourself if you learn to raise your mouth, okay? Open up. Make sure people hear you, especially when it comes to your own body, your own illness, all right? The only way you're going to get answers is if you make yourself heard, okay? If they're not answering your phone call, and if you're able to drive, then go there, all right? And if they say, hey, you're not here for an appointment today, yeah, no, whatever, okay? But you're not calling me back. All right? How can I possibly get my prescription if you're not going to call me back? How can I possibly get in for an appointment if you're not calling me back? So I'm here to make an appointment because that's the only way it's going to happen. Get in there and open up your mouth and make sure that they're hearing you so you can get what you need for your illness. Okay?
I'll tell you a quick story. A young man I take care of in his mid-20s has done very, very well. And as most young 20-somethings, sometimes he's doing so well he doesn't come in the office the way that we like him to. And one day I was running a busy clinic, and my clinic team members came and said, hey, so-and-so's out in the lobby and he demands to see you. And that was very unusual. And I said, what's he got going on? They said he won't say, but he's not leaving until he sees you. I thought, well, crap, stick him in a room. So I get him in a room, and I get some free time, and I come in, and I close the door, and I sit down, and I said, what's going on? He goes, I have to talk to you. I said, apparently. And I said, what's wrong? He goes, I got a real big problem. I said, spit it out. He goes, I got a girlfriend. I said, how's that a problem? He goes, I need Viagra now. That's a true story. And guess what? I gave him some Viagra. Yeah.
Very good. Very good. But again, going back to things, you got to be able to communicate with your healthcare team, all right? You got to do it one way or another, all right? If you're not getting it by simple, conventional methods, then go to the next step. Make yourself heard, all right?
Stuart said something very important. I don't know if you heard what he said. He said your healthcare team, right? I like to talk about a village, all right? And the village is not a village of two, you and the provider. That village is an extended village. So that village can include the medical assistant. It can include the infusion nurse that knows you better than anyone else in that office. That can involve the nurse practitioner that you see every other time, or the social worker. My point is, don't be proud. Seek out someone that's going to listen to you. And if you're not connecting with your provider that particular moment, ask someone else. My point is, it's a team effort. It takes a village to beat this disease. Call on all the villagers.
It just in terms of a lot of people don't believe that these things can happen, and I still can think of a neurologist and speaking to him not all that long ago and asking some questions and discussing some things. And his response to asking him those questions was, and I'm going to use the initials, he did not, that's BS. I'm the doctor, you're the patient. And that, needless to say, I never stepped foot in that office again, but that, those attitudes are...
That's what you should do, yes.
So...
to be an RN before this, and we didn't have the Doctor is God 101 in the curriculum, but it happens. It still happens.
There's no class in med school about paternalism. That's not a course that you're given in medical school. And I think about being a plumber. If you hired a plumber to come in and move your sink, and he started to tell you that wasn't the right kind of sink and you want a different sink, you get a different plumber. And a doctor's not better than you because they're a doctor. They just read books you didn't read. But you know your body better than they do, and it's a team effort, right? And just like getting another plumber, sometimes you have to ask the provider and say, hey, this isn't working out. Can we do this differently? You're allowed to say that. You're allowed to say that to me because it's about you and getting your needs met. If you don't take anything away from tonight besides a fantastic meal, I want you to take away a license to be selfish because you don't get to do it a second time.
Great. Next, so many people ask me on social media, at our meetings, in the streets, wherever, they want to know what I know about stem cell therapy. And I say, I'm not a doctor. Speak to your doctor. But they can't because they don't know how to communicate with them. They want to know more about it. They want to know what happens if they go to Dominican Republic or to Mexico or Russia. The big news is about Russia. So please tell everybody what's happening with stem cell therapy these days and why they should not pay attention to those people that want to stick a needle in their belly, draw out fat, stick it back in their belly 24 hours later and say, you're cured.
How many of you have had a well-intended person tell you that you should look into stem cell transplantation?
Oh, there we go. Half the room.
Look around the room. Very, very common, right? Sometimes people with the very best of intentions recommend stuff that they might not fully understand. The idea of a stem cell transplant at first blush sounds awful sexy. I'm going to go somewhere, they're going to take out my bone marrow, they're going to put it back, and I won't have this disease any longer. It's not sexy. Stem cell transplantation works like this. They take your stem cells out of your body and they put them on ice. And then they murder you. No, I'm being serious. They give you lethal doses of chemotherapy that ablate your immune response, destroys your bone marrow. You're going to die. But before you die, they give you back your own stem cells and pray that they take. A stem cell transplantation is arguably one of the most severe procedures that I'm aware of as a physician. Now, stem cell transplantation is not prime time in the United States. What do I mean by that? Stem cell transplantation is not ready for you to go and have the procedure done at your local CVS. It still deserves to be in the context of research. I've done 4 stem cell transplants in my career. It's when I worked at a giant university, OH! And we were running a stem cell transplantation program, and we transplanted 4 people. It's a very, very hardcore procedure, and it's not for most patients. Now, one thing that I want to make very clear is you want to avoid stem cell tourism. There are places around the country and around the world, exotic places like Mexico, India, Chicago, where you can go and pay someone $25K and they'll do something to you. And they might be doing a stem cell transplant, they might not. The FDA, thank God, is cracking down on some of this to prevent you from being taken advantage of and being placed at risk. I do think that stem cell transplantation will become a viable therapy in MS in the next 10 years. Let me repeat that. I think that stem cell transplantation will become a viable therapy, but it's not yet. When someone comes to me in clinic and says, I want a stem cell transplant, what I hear is, I'm sick of this disease and I want to do something to beat it. They don't understand what they're saying necessarily about a stem cell transplant. And so I think it's okay to want to learn about that. I think it's okay to study that. I even think it's okay to do it in the context of a safe clinical trial. But I do not recommend going to Baja California, Mexico, and having your bone marrow swapped out. It's a scary, scary thing.
Especially in that portion of Mexico.
Yeah, that's true.
Right. So thank you for that. So now let's talk about lifestyle choices. And we're talking about concerning the medications. So a person is not faring well from a certain medication that they might be on now, and they need options for what else they can do. And obviously, we got 16, 17 different medications on the market right now. But do you speak with patients about what serves them best for their lifestyle? Meaning that if they have children, is it going to make them fatigued? If they're actively running around the United States providing MS educational programs, do they have time to get sick from their medication or, for 24 hours or whatnot? Do you work with people based on what's going on with their own lives to say, hey, this drug would be better for you than this medication?
Well, Stuart's talking about disease-modifying therapies, the medicines that we use to slow down MS. And when I think about a disease-modifying therapy, my first thought is efficacy, right? I want to find the most effective drug that you're comfortable with. That's where I start the discussion. That's not where I end the discussion, that's where it kicks off. And we need to find a drug that's going to fit your needs. Stuart talks about traveling a lot. Traveling with a bunch of shots that you have to keep refrigerated is a no-go. That doesn't work, right? So if you need to swallow a pill twice a day and you can't remember to take pills, that's a bad drug. Or if you take a medication which is highly effective and makes you poop your pants constantly, that's not the right medicine. So we have to find a medicine that's the most effective medicine you're comfortable with, that you can tolerate, with the side effect profile that's safe, and something you can pay for. If any of those things don't work, it doesn't work. When I'm trying to find out if a medicine's okay, there's 5 things I'm thinking about. Number 1, are you having attacks despite taking it? Because if you are, it ain't working. That's kind of like saying, if you're on birth control and you get pregnant, it didn't work. Similarly, are you having new spots on your MRI? Because a new spot on your MRI is the same thing as an attack. And if you're on a medicine, it didn't work. Are you having changes on your neuro exam? When I tell you to touch my nose and pull my finger, I'm testing your neurological functioning, and I'm trying to see if it's the same as it was last time or if it's gotten worse. And if it's gotten worse, I'm not okay with that. But we also have to ask, is it safe? Safety changes over time. I'll give you an example of a highly effective drug, which rhymes with matamizumab, and you take it in the vein once a month. And there's a risk in some patients, and that risk can increase over time. And someone who found that drug to be safe as houses might 3 years later find it not to be okay. It can change. But the fifth one is tolerability. You have to tolerate your drug. I have a patient, I gave them a drug, and the drug worked really, really well. And it was very inexpensive. And it slowed the disease down. And they didn't have attacks. And they didn't have new spots. And their examination was crystal clear. Except it made her hair fall out. I'm being serious. And she did not like Aaron. And that's not okay, and so we had to change the drug. Make sense?
Yes. Yes, makes sense. Makes sense, right, everybody? I'm pointing at something in the back of the room that needs to be handled, that's all. That's great. Thank you for that. Anybody have anything that they want to ask towards this? No? You're getting, all right. We got a few more to go here, all right? All right, so now let's talk about how people can manage their MS. What can they do with their lives? What's best for them to do? And does anybody have any questions that they might have of how, how best to live with their multiple sclerosis these days? Or are we already answering everything?
Any of you heard of my phrase, I want you to be 4 for 4 in your fight against MS? Raise your hand. You ever heard of being 4 for 4? Say it with me. Be 4 for 4 in your fight against MS. I think there's 4 things I know about that can slow down multiple sclerosis, and I want you to do all 4 of them. The first one is to take an MS medicine and make sure it's working. Right? That's not an easy thing to do, actually. Number 2 is not to smoke cigarettes, because smoking cigarettes speeds up your MS by almost 50%. Did you know that? Let me repeat that. Smoking cigarettes speeds up your MS by almost 50%. Hey, James. The third one is to exercise as part of your lifestyle. People with MS that exercise as part of your lifestyle, it slows down their disease process. It improves their energy. It improves cognition. It minimizes spasticity. It's good for you. And the fourth one is to eat clean and supplement low levels of vitamin D. That's being 4 for 4 in your fight against MS. And those are things that we can do to impact the disease process. I can't tell you how many people that I've worked with, when they finally do that, come to me and say, Lord God, Aaron, you were right. I'm doing much better. And it warms my heart.
So it seems like half this room put up their hand that they knew what 4 for 4 is. Are you practicing it? Are you practicing it? Great. Do you have something you want to add? Can you clarify clean eating?
So there's no magic. She says, can you clarify clean eating? There's no magic diet that's been proven to slow down multiple sclerosis. Now, if you go to the bookstore and tell someone you have MS, which I recommend you do if you want to have a good time, they'll say, oh, good, and then they'll escort you over to a section and they'll show you all these books written by people with letters after their name, and there's no science that proves that slows down MS. But having taken care of folks with MS for a decade and a half, eating clean can make a major impact on your energy levels. It can help you lose weight, which makes it easier to move around. And to make it very simple, I recommend that you eat real food. McDonald's is not food. It's delicious, but it's not real food. Diet 7-Up is not real food. Yeah, that's also tasty. But the reality is, I recommend that you eat things that are real food. And if it has ingredients in it that you can't pronounce, you shouldn't be eating it, in my opinion. I like to recommend a heart-healthy diet. And at the risk of a selfless plug, on my YouTube channel, I've got a bunch of videos on nutrition where I talk about clean eating. But if you're eating food that's things like apple, chicken, like there's one word, that's the ingredient, you're probably, or apple chicken, you're probably doing very, very well. And I know that sounds like something your mom would tell you, except she's right. And I challenge you, if you cut out excess sugar out of your diet, I challenge you if you cut out fried food and fast food out of your diet, I challenge you that if you cut out soda pop out of your diet, do it for 3 weeks and find out how you feel. You would be amazed at the change that I've seen time and time and time again when patients finally take that advice. It's a really, really big deal, guys.
I've got a question about secondhand smoke.
I thought you were going to say I have a question about sex. Sorry.
Well, I'm good with that. I don't smoke, but I'm exposed to secondhand smoke on a fairly regular basis. What can you say about that?
Being exposed to secondhand smoke speeds up multiple sclerosis. That's what I can say about it. Now, it's not my intention to get a family member or a loved one in trouble. But my point is that we have to take ourselves very seriously when it comes to MS, and we might have to discuss going in the garage for smoking, because it can make things worse.
Yeah, but it's not that it could just make your MS worse. You could still get cancer from it as well.
Yeah, there's other things that are not so good.
That's right.
But that does count. The reality is that exposure to smoke as a child, pre-puberty, increases the risk to develop MS. And having exposure to smoke can speed it up.
All right, next. It's our final topic, and then we're going to go to a live Q&A, all right? But the final topic is that there are a lot of patients, again, that catch me on the road and everywhere else. And there are several doctors in the country that I know are doing this, and that's concerning concierge medicine. All right, and what is it about concierge medicine, they're asking me, that makes it so much better than dealing with the regular doctors that they've been dealing with, over many years? Where's the benefit for them to be involved with this? And again, there are doctors in Georgia, Alabama, Texas, Maryland, Wisconsin that I know of, these doctors that do very, very well with it. And so the people that are seeing them are very happy, but how do they get other people to see them? And so I want you to explain to everybody about this concierge medicine.
Anyone heard of concierge medicine? So concierge medicine, or membership medicine, or retainer medicine is actually the oldest form of medical practice in the world. It's the idea that the patient pays some money in exchange for services. Right? That's really what you're talking about. In the United States, it's not the norm anymore. It actually used to be. And in the United States, most of us have insurance, and we access medical care through the insurance. I've recently had some frustrations with that because insurance is happy to pay me for 15-minute visits. And if I want to take 20 minutes, I'm allowed, but they don't pay me as much. And if I want to take 30 minutes, they're going to pay me for 15. And one way to get around that is just to see people faster. Any of you that have ever talked to me, I can't do that. And so concierge medicine can take a lot of different forms. Sometimes you completely avoid insurance and you pay a primary care doctor a set fee, and that's all you pay. And if you need to interact with them, you interact with them. Sometimes you might use insurance and there might be a membership fee on top of it to extend the amount of time that you have. And it allows the provider to have a smaller number of patients so they can spend more time with each patient. My message to you is not that that's the best thing. I'm not saying that at all. It's an option, and each of you have to figure out the value proposition of what's best for you. Some patients are fine and dandy like candy using insurance, and that's great. Some people want something more, and the only way that the provider can provide it is through a membership medicine or a retainer. So it's something that I think is also a reflection societally about the limitations of third-party payers and insurance. And I think as you see doctors do it more and more, what you're seeing is them pushing back against a 15-minute visit. Because I don't know about you, but I don't think you're a car and I'm not a factory. We're dealing with something much more important.
So there's a doctor that I know in Alabama, all right? He sees 30 patients a day, and he's a concierge doctor. Where does he find all the time to see 30 patients a day and give them all that extra time?
I don't know. I know the guy you're talking about. He's one of the very best in the country, but I don't know how to do that. You know, the bottom line is there's no right answer except for what works best for you. And it might not be the first person you're referred to, and it might not be the second. And you might have to have a couple conversations to find the right provider in a way that works for you. My point here is you got to keep looking until you find that provider and that relationship that works best for you. And if that is a standard visit, God bless. And if that's concierge, God bless. But the point is, it takes a village to beat the disease. And you're trying to bring on board one of the key village members, your MS provider. You got to make sure that you like that village member a lot.
So when they're seeing a concierge doctor, how does that affect if they need infusions or if they need, well, just start with infusions. I mean, let's go with that.
Oftentimes, concierge fees don't apply to procedures. So if you're paying a doctor a certain sum of money and you need to have a colonoscopy, that's through insurance. Most providers that do concierge, they require the person to have insurance for all those other things. For medicines, pills they take, infusions they receive, tests that they have. That's done through insurance still. And that concierge membership fee applies directly to the time spent with the provider. That's how it's done most commonly. There's a question in the back of the room.
So as far as physical therapy, would you just refer out then a concierge doctor? Because if you're not in a large facility or a large practice, you don't have access to maybe all of that right there. So you just refer out then?
I've practiced MS in many, many different environments, in a bunch of different cities and in a bunch of different ways. And every place I've practiced, we amass a team. Specialists that we refer to, urology, physical therapy, speech pathology, neuropsychology. Those relationships don't change if you're doing concierge medicine or if you're doing telemedicine. You still identify the best person for you. I have patients I take care of and they live in Colorado. They take physical therapy and they don't travel to Ohio for it. We find a physical therapist with qualifications local to them, and that's where they had their PT done. The key important thing is that they have that team member that they can refer you to, whatever shape or form it comes in.
Does anybody else have any questions about this? If not, I want to say thank you for doing this, and then we're going to cut to just the live Q&A, all right? But for that, you could stand. For that, I'm going to stand. Wait, it's going to take me a second to stand. So I want to thank everybody for being involved with MS Conversations Now. I got this boot on. I got a bad ankle. I'm stuck to this wire. I got a lot of things going on here.
Don't fall.
No, I'm not going to fall. So again, though, before we cut to that, I just want to again say that we want to thank Sanofi Genzyme and Celgene for giving us the funding to do tonight's program. And then I'm going to turn it all over to Aaron, Dr. Boster, all right? And I'm going to run around the room with a microphone, all right? But thank you again for allowing us to do this.
Let's say thank you to Stu. All right, guys, it's just us.
All right, so first question is over here on this side.
As usual. I want to return to the topic of selfishness and how to get a good doctor's appointment going, because that's like my thing, selfishness. So in any case, what I have found is when you go to make your 6-month or 12-month follow-up appointment, if you have a really cool doctor, and I have two, ask for the last appointment of the day, with apologies to doctor spouses. Because sometimes you'll get them to stay until 6:30, just having a conversation that's really important. So that's just a pro tip.
And I want to repeat what you said in case folks on the other side of the room couldn't hear it. It's actually an outstanding pro tip. If you have a lot you want to talk about or you think you need more time, a trick is to ask for the last appointment of the day. Because you know and the doctor knows there's nothing afterwards. They're not waiting for another patient. And you're absolutely right. If I have, for example, a family that I'm seeing where I'm diagnosing them with MS, and we're not done yet, and I'm going to bring them back, I always bring them back to the last appointment of the day so that I'm not limited in how much time I spend in talking to them. That's actually a great tip. So tomorrow, there's a bunch of providers in Columbus that are going to be like, why are they all asking for the last appointment of the day? We won't tell them about this.
Dr. Boster, there's so much always talked about relapsing, remitting, and no disservice to them. There are those that have primary progressive or secondary progressive, and very little, as far as we're concerned, is talked about that and the progression of it. And we'd like to see and hear more of that, if there is anything. And that's to the point that they get, is that there's nothing left, and they give up.
So,
that was my question.
so two questions touch on a very sensitive topic. And there's a lot out there being done, discussed, promoted, researched on relapsing remitting multiple sclerosis, and in particular, early relapsing remitting multiple sclerosis. Am I doing that? Am I right? Can you hear me in the back? And so, what about progressive MS? What about someone who's had MS for 25 years and they haven't had an attack in 15 and yet they're getting worse? What about someone with PPMS? So let's break that down. Number one, first thing, MS medications do more than slow down attacks and new spots. MS medications, particularly some of the newer medications, are able to slow down disability progression. I'm going to get slightly scientific on you for just a quick second. There was a giant study recently done where they took a bunch of early relapsing remitting patients and they gave them this great drug which decreased their attacks. And they looked at, over a 2-year period, how much disability those people had collected. And then they did some fancy math where they removed the disability associated with the attack. And what they found was all the people in the trial still progressed in their disease underneath the attack. The reality, guys, is that MS is a progressive disease from the get-go. And it's not just the person in the latter half of the disease that's suffering from progression. When you study thinking and memory in a person newly diagnosed with MS, and you compare them to age-matched controls, they have a slight drop. So it's not as if you escape this. This is real. And the MS medicines have been proven to slow disability progression independent from attack. So I don't want to stop a medicine just because you're not having attacks. Maybe you're not having attacks because you're on the medicine, but even if that's not the case, it slows down the disease. There's an MS medicine that was studied a few years back in primary progressive MS. And all the people that were on placebo got worse. And all the people that got on the drug also got worse. But they got 25% less worse. It slowed their disease by 25%. I won't insult you by asking you if you think that's important, because we know the answer. That's very important. So the first comment is that there are things that you can do to improve progression by taking these medicines. The second thing is, you don't get a buy from the rest of life just because you have MS. And if you have MS and you don't embrace exercise as part of your lifestyle, you get deconditioned. The same way that I get deconditioned when I don't exercise. And you may find that you're walking slower, not because of your MS, but because you're horribly out of shape. I'm being serious. And by embracing exercise as part of your lifestyle, you can improve how you do. I'm going to give a very quick example of a man that's very important to me. He was my algebra teacher. He was also, years later, my patient with primary progressive MS. In an era where there were no therapies to help him. And he was having trouble with his walker. And he was a really tall guy. Now, I'm tall, but I mean, he was like huge. And his family was talking to him about sitting in a wheelchair. And he said, I don't want to. So we got a life jacket on him, and we took his walker in the YMCA swimming pool. And this guy wearing a life jacket started to walk laps. And he did it religiously 4 days a week. And after 3 months, he came back in, and the MA came and said, Dr. Boster, he won't go in the room until you come out in the hallway. All right, so I went out in the hallway. And he looked at me, he said, you ready? I said, yeah. He picked up his walker and he walked 25 feet. He didn't do that with a medicine, guys. He did that by sheer force of will, by reconditioning his body. And I think that's pretty darn impressive. People with MS can accrue symptoms. Symptoms can destroy the quality of your life. And symptoms can be treated. I'll use an example of a bladder problem where you can drink half a Coke and then you wet yourself. That's horrible. And we can treat your bladder problem. Does it slow down your MS? Maybe not. Does it improve the quality of your life? Heck yeah, it does. And so by focusing on symptoms, we can improve what's going on. I hate it. I hate it. When a doctor says there's nothing we can do for him, he's got SPMS, send him back to his primary care. Wrong. That's incorrect. There's a tremendous amount that we can do. And we have to just dig in. We can slow down progressive disease in 2019 using medicines. We can recondition someone. We can improve their diet. We can remove things that are causing them problems, and we can treat symptoms. And so we're not done with you. We're just getting started. That was a great question. Thank you, guys. There's one back there.
Yeah, I'm trying not to cry. Thank you so much for your time. We moved a couple of years ago, and you were my doctor before we moved. And I haven't been able to find a doctor yet that really listens and gives you the encouragement and the extra, the boost of energy, I guess. Just the sharing of knowledge and the different opportunities that are out there as far as different medications for different symptoms and things like that. So I know I need to find a different doctor, and you touched on that earlier. Finding if they're not helping, then you need to find a different doctor. But what would be the best way to determine, or how do you find a new doctor? I don't even know how to ask what I'm trying to ask.
Let me respond with 4 things. Thing number 1 is thank you. Thing number 2 is road trip. Sometimes you got to travel a little while to find someone fantastic, right? And so I have plenty of patients that share with me they travel a distance to see someone that really clicks with them. And this is not a primary care doctor that's taking care of a cough. This is something much more serious, in my opinion. And so you might need to travel a little bit to get to a doctor. How do you find an awesome doctor? You talk to your community, you talk to your village. Who are you seeing? And that village can extend internationally. Number 3 is a selfless plug. A couple years ago, I had a no-show in my clinic, which means I scheduled a visit and somebody didn't show up. And so I took out my phone and I turned on the YouTubes and I talked into it for a half an hour because I had nothing else to do. And I posted it on the interwebs. And that was the beginning of developing a YouTube channel. So I have a YouTube channel where I make educational videos to help educate people in between visits. And it's something I've actually become really passionate about doing. I'm not giving medical advice, I'm just giving medical education. And I'm not the only doctor doing it. There are increasingly MS neurologists jumping on the interwebs providing medical education. MS Views and News is probably one of the largest repositories of MS lectures I've ever seen. As Stuart and his team travel around the United States and listen to lectures from the who's who in that city talking about the latest and greatest, they record it all just like this, and you can watch it on the internet. The 4th one is the theme tonight. And tonight's theme is be selfish. It's your body and it's your brain. And if you're not happy with what you're getting, keep looking until you find what you're looking for. You can do that. And there's a bunch of people in this room that would help you do that. Thank you for being brave and asking that question.
I also, a suggestion, so I have Dr. Boster on retainer because I live in Cincinnati. So I have my neurologist there at home, close at hand if I have an emergency, but then my every 6 month or every year, whenever I need to make an appointment with Dr. Boster, I'm in with him already, and so I utilize that. So just like you're here tonight, you can schedule that in a year from now or 6 months from now. That way you have the specialist, but then you also have your close to home.
She says, I'm probably calling for the last appointment.
Okay, I'm asking this on behalf of one of my support group members who takes
Famperdine.
Yes. And they were curious that when they stop taking it or take it a few hours after they are supposed to, they were wondering why they lose mobility sometimes.
So this is a patient who has a symptom and they're taking a medicine for it. And they find that the benefit of the medicine changes on the timing of the medicine. And without answering that specific question, it comes back to a very, very important point. When your doctor says, take this medicine with food, they're not just like saying that airy-fairy. It's because scientifically the medicine isn't absorbed unless you eat. If a doctor says you have to take this medicine every 12 hours, it's not because they're a time Nazi. It's because the drug wears off after 12 hours. And so those recommendations of how to take the medicine are actually based in science. It's not just based on whenever it's good for you. And sometimes we can really change the value of a medicine by changing how you take it. Now, Stuart, I know you jumped over there, but there's a gentleman that was very, very politely waiting. Just yell real loud.
I was wondering, is there any information about the perhaps cause of multiple sclerosis, and also is there anywhere in the world or a place that one could go to where MS is known to be lower or higher? Is there a climate that causes it or has something to do with it that you could go to that would
So the gentleman's asking a very relevant question. Why do I have this? What happened? What caused it? Right? And the real answer is we don't know. All right? But I can give you the best knowledge that we have to date. Right? And it's a 3-step process. Process number 1 is genes. We have genes that code for the immune response. So your immune system. And certain constellations of genes predispose people to have more or less active immune responses. Now, this isn't true for every single person, but populations that hail from Western or Northern Europe tend to share genes which increase the risk of autoimmunity. Now, that doesn't mean that every pasty white kid's going to get MS, but as a population, there's a higher risk. All right? So the genes have something to do with this. The second piece is there are environmental factors that can increase or decrease your risk. Being exposed to secondhand smoke, being morbidly obese as a child, having a high salt diet, having low levels of vitamin D, have all been shown to increase a child's risk to develop MS. Now, that doesn't mean that every fat, pasty white kid is going to get MS, because that's not true, all right? But it increases their risk. The third step is we think that the immune system makes an error in judgment. Your immune system sees a virus and says, well, that's a virus, and it makes an arsenal against the virus. And by accident, that arsenal misidentifies part of your body as a foreign invader. By accident. It's kind of like if I made a key for one car and by accident it worked in another car. It wasn't supposed to, but it does. And once you set that up, that's called autoimmunity. You can't undo it. That's the best we understand, that there's a genetic predisposition with environmental adjustment, and then there's a bystander immunity that causes MS. We're still working on it.
All right. We can't just stay with one person right now because we are running out of time too. There are a couple of questions on this side of the room that I need to get to, but also there are people writing in from the internet.
Internet.
Right. There are people writing in from the internet, and there are just some people that gave anonymous questions, all right? One wants to know, how does one find the balance between helping when it comes to encouraging somebody with MS to utilize proper nutrition and hydration?
So there's a balancing act when you try to help somebody, right? And sometimes you can care too much, sometimes you cannot care enough. And I think at the end of the day, you can't make people do stuff they don't want to do, right? And I think the best that you can do is tell someone that you love them and care about them, and that you're concerned and you just want to share something that might be helpful, and then shut up and let them figure it out, right? I'll give you an example. You might talk to someone who smokes cigarettes and say, I don't want you to smoke cigarettes. They say, that's nice, right? It's their body. They're allowed to make that decision. They're an adult. And so I just tell people, I would love for you not to smoke. I'm worried about you, but you're allowed to do what you want to do. And so here's how we're going to leave it. You keep smoking, but I reserve the right to ask you how it's going, and then you can tell me it's going great. And I just want you to know that I care about you, and that if you ever want help quitting, I'll help you. And I think that applies to diet and exercise as well, right? If you push too hard, they're going to run away. And you don't want to do that. That was a great question. How about another one?
My question was regarding chronological age. It seems like there's a lot of, call it controversy or whatever, whether it's age 60, 65, 70, where you hear, no, it doesn't make a difference, or then there are other MS neuros that will say, you know, we're going to stop the DMDs, you know, at this age, you know, nothing more can be done, and others will begin a DMD at age 70. Where do you stand or believe with that?
So you touch on the pulse of something that's very hot. It's a hot topic in the United States right now. And it's a question of stopping. Do we stop the medicine at a certain point? The theory, which is based in some science, is that as we age, our immune systems become quieter. And so since we have an autoimmune condition, if the immune system becomes quieter, maybe we don't need the medicine. And there's some very controversial research that suggests that some of the MS medicines work less well when you're older. And so they recommend that we stop that. There's actually clinical trials going on in the United States studying the question of whether you should stop. Where do I weigh in? I think that's utter hogwash. I think it's nonsensical, and it kind of makes me mad. Why? I've had many experiences where someone who is in their 70s has an attack. It's not very common, but they don't bounce back. And so I want you on an MS medicine as long as you have an immune system. I don't think we should treat people that are dead. I really don't. I think that's inappropriate. But if you're still alive and you still have neurological symptoms that you like, for example, seeing, hearing, eating, moving, if there's stuff that you enjoy doing, I want to maintain that. And taking an MS medicine is one of the best ways to do that. One of the concepts that I am fond of is de-escalation. I don't know that we need to stop your medicine, but I think that we can constantly revisit the risk-benefit. And sometimes it behooves us to ratchet down the intensity of the medicine. I don't stop it, but I ratchet it down. You touch on a very, very hot topic in the United States. Where do I weigh in? I'm going to treat you until you die.
Anything else? No, that's...
Okay. You know, taking it a step further, my insurance company says, Stuart, you haven't had a relapse in 11 years. Why should we keep giving you medicine? And I said, well, if you want to take me off of it, it's going to cost you $1 million to fix me again.
So maybe you're not having attacks because you're on the medicine.
That's right. That's right. So, you know, that's another thing that insurance companies will do whatever they can do to get you off your medication. It doesn't have to be age-related. It could be just that you're doing well. And, you know, you're doing well because you are on the medicine. So, again, fight. Next question coming up, but I'm not running there. Used to run. That's probably why I have a bad ankle.
Actually, I have a question in regards to how often about medications. So, speaking Tysabri, for example. Okay, so do you think that after you've been... Whoa.
That's good.
Sorry. Okay. Anyways, after you've been on it for an extended period of time, that it's okay to stretch it out maybe to 6 weeks versus 4 weeks? I mean, are you finding that more common?
So she asks a very enlightened question. And you know, something which I have always found to be 100% true. When you get a group of people impacted by MS together, collectively, you have your fingers on the pulse of this disease, And collectively, you know more about what's going on than a lot of doctors, and I'm always super impressed by that. This was a great example of a super question. There's a medicine that is taken every 4 weeks, and it's been around since 2004, prescribed every 4 weeks. That's how we give it. And it works really, really well.
28 days.
Every 28 days. And what's been discovered recently is that if you extend it to every 5 weeks, it doesn't seem to impact the efficacy. It doesn't seem to make it worse to take it every 5 weeks. And some people have found that if you extend it every 6 weeks, it doesn't really impact how well the medicine works. That's in groups. So the take home here is medicine is an art based on some science. And together we have to figure out what works best for you as an individual. I'll give you a great example of a patient of mine, a guy that I adore. He used to live in Ohio and now he moved down south. And I had him on a medicine that you take twice a year. And he found that the last month or two, it kind of seemed to wear off. And I didn't believe him until I brought him in and I examined him. And he was clumsy and he was dropping things and he was unable to walk. And right after I dosed him, that went away. So I ended up seeing him once a month, every month. And I saw that sure as heck, when he got to month 4 or 5, it seemed to wear off. So I did something which is called off-label. I started to give the twice-a-year medicine 3 times a year. And guess what? He did great. And so we now give him this twice-a-year medicine 3 times a year. Is the take-home everybody should change how they take their medicine? No. But the take-home is nobody is like anybody else. And we have to make the right fit for you. And so in this particular example that you give, some people have found extending the dose is great and it works super for them. I have other patients, they don't handle it very well. And this speaks to a bit of the art of medicine. We don't have all the answers yet. We have no room to be proud, but we have to be really curious and try to keep knocking down that door. Great question, thank you.
And to have a doctor that will do that for you, you need to make sure that your doctor is going to aggressively treat the disease and not just be there to say, hey, I've got another patient. All right? You got to, if you want to be ahead of things, you got to get ahead of things by seeing an aggressive doctor.
Grr. Grr. Yeah.
Hi, Dr. Boster. You've been treating my daughter Brianna since she was barely 19. And so for the past 7 years, you've given excellent care. We have never felt like you've rushed us through an appointment or that you never had time for not only her questions, but mine as well in the team effort to care for her. Obviously, over that 7-year span, we have spent thousands of dollars on deductibles and over-the-counter healthcare needs and quality of life. So if you go to the concierge form where membership fees are due, you're still having to meet your deductibles with your insurance company. So how does that work? Is any of that membership fee covered under our insurances? Or is that in addition to everything else that we would currently be paying out?
So this is a question talking about concierge medicine, all right? And there isn't one size fits all for concierge medicine. That's a conversation you want to have privately with the provider. And I'll give you an example. Sometimes the concierge fee is paid for by a flexible spending account, tax-free dollars. Sometimes, based on need, the doctor can flex or waive or slide and scale that fee. Sometimes they won't. And again, that's what I was saying earlier, that you have to find the right fit for you. And that fit includes finances. So no matter what it is, no matter whether you're asking a concierge doctor how they explain their membership fee, or if you're just saying you want me to do that test and it's $4,000, I don't have that. We practice medicine in the real world. We practice medicine in the real world, and we have to make it fit within the context of the real world, including the finances. I will share something interesting with you. I talked to a patient recently, and we were discussing membership fees and a bunch of other things, and she said, you know what? I spend more on my gym membership and on my manicures and pedicures than that person's fee. I might make some decisions to change that. Now, that doesn't mean that she's forced to have ugly nails, but my point is that as you think about value, you have to take the whole thing in consideration and figure out what works best for you. That's a great question. Thank you.
Hi, Dr. Boster. My question is, okay, so I work in an office setting currently, and so since I'm not always able to be as active as I want, especially in the winter, one thing that I do daily is drink a lot of water.
Nice.
But what I want to make sure and not be naive to assume just because I get monthly labs done that because I'm drinking tap water, because it's easier for me, I have access to that right in the area that I'm in as opposed to going down to the cafeteria and buying. Is it naive of me to believe that because of the labs that I get once a month that I would see if that tap water was bad, would there be something showing?
Do you live in Flint, Michigan?
I do not, but I don't want to assume anything, so
she brings up an important point about understanding the food that you eat and the water that you drink and the fluids that you take in. Most tap water in Columbus is pretty solid stuff. And I personally, for better or worse, wouldn't be too worried about that. But if you are concerned, let me throw out a cheap option. Buy a Brita water filter, right? And fill up the tap water, keep it at your desk, and let it go through the Brita, which is a filter. They make even mugs that are filtered water. And so maybe just a simple trick like that will help you filter your water and give you a sense of confidence that, okay, my water's filtered, so if there's weird stuff in it, I'm okay. And you need to avoid drinking water in Flint, Michigan.
Hi, Dr. Boster. We touched on it being genetic, hereditary. At what age would you start being aware of your child's health care if you have a history of MS in the family? Because getting an MRI is hard to do.
So she brings up something which is germane to every parent in the room. If I have this condition, what's the risk of my children? I'm a parent. Actually, my kids are standing right back there. Guys, wave. Max and Betty? Yeah, those are my beautiful children. And it's a very reasonable concern. Any parent newly diagnosed asks me two questions. Will it kill me? Will I give it to my kids? Every single person, which is very reasonable. That's what I would want to know. I do not think that we need to get MRIs on munchkins. The risk of a child getting MS, if you have MS, is about 1 to 3%. That's the statistics. And I believe that you could lower that risk by avoiding exposure to secondhand smoke. Now, no one says, smoke up, Johnny! But you want to really impart upon them the fact that there's an additional reason why you don't want them to smoke. Keeping them physically active and avoiding morbid obesity. And if they have low levels of vitamin D because they live, say, in Columbus, working with their primary care physician, their pediatrician, to supplement low levels of vitamin D can help them. And then you need to not have fear and let them live an exciting life. And God forbid, if something happens, we're going to address it. But those are the things that I know how to do to lower that risk.
All right, we have a question here, we have a question there. I have a question or two here, and then I think we're going to have to wrap it up because it's beginning to get late.
Hi. There's an organization that's sort of pushing brain health, which I know you are a fan of as well. And they talk about the gray matter and the white matter. And it's kind of confusing as far as a patient, what I need to know about myself to help be an advocate when I go to my doctor. I don't know if it's related to knowing how many lesions I have and where they're located. Does that information bring value to me as a patient or not, since I can't do anything about it?
So she asks a rather complex, excellent question about brain health and about self-education. Some patients really benefit from a deeper understanding of why. Some of my favorite patient archetypes are engineers because they think the way a neurologist thinks and they want to understand the system. And I kind of love that because I'm a nerd. Other patients, it freaks them out. And it doesn't make one patient better or smarter or one patient not care, but it's what works best for you. I have some patients, they want to look at their MRI for like 6 years. They want to stare at it and discuss it. Other people say, don't show it to me, just tell me if it's okay. And I think you have to do what's best for you. I like educating unless the patient says, please stop. I'm serious. And so I don't think there's a right answer. I think if you seek a sense of empowerment by understanding, then you should seek that out. And I think if that just kind of scares you and freaks you out, then you can just listen to the recommendations. I don't have to explain the science behind being 4 for 4 for you to do that. Some people don't want to know the science. They just know they shouldn't smoke and they should take vitamin D and they should exercise and take a medicine. Other people want me to explain why. And so I think you have to do what's right for you. Remember, the theme tonight is to be selfish.
Question.
You talked about supplementing vitamin D. As a person with MS, what levels should my vitamin, or anybody who has MS, what levels should their vitamin D be at? Not a normal person, an MS person.
So my preference is that people impacted by MS maintain a vitamin D level that's between 50 and 100. Now notice that you can't figure that out unless you have a lab. So I'm not telling you to go to CVS and buy a whole mess of vitamin D and eat it. That's actually not a good idea. I am suggesting that your clinician draw some blood and find out what the level is. The normal range for adults, like the general population, is 30 to 100. And we find that for MS, 50 to 100 is the range that we like you to be in.
Question. Person wants to know, from seeing the new commercial about a new MS medication, what is the risk of cancer? And how could they find out more about this, and if there's any data actually involved with cancer from this medication?
Are we allowed to talk about medicines?
No.
So let me answer it in a general fashion. Commercials are a great way of communicating, right? Commercials are made with a purpose so that you can hear about something and get excited about it. And when there's a commercial for a drug, I think that should spur you into talking to your doctor about it. So if you hear about a drug and you're curious, that's good. Schedule an appointment with your doctor and say, I heard about this drug. Could you tell me more about it? Because that's where the information should come from. And I think if a commercial spurs on the conversation, that's awesome. But it's not gospel from up on high. It's a commercial. And so that's how I kind of approach that. I love the fact, I actually like MS commercials, and I'll tell you why. It's because it normalizes having the condition. It normalizes the fact that 1 in about 350 people in Ohio have MS. That's not rare. And so it normalizes it.
Are you done?
Yeah.
Great. I didn't know. I mean, I know you go on and on and on, so I just want to ask. Hey, I have a question for the audience. Did you enjoy this format? Great. Did you enjoy Paul Pelland? How about this guy? I want you all to drive home carefully, be safe, have a great end of year, have happy holidays, and just remember, it's not OH, it's MSVN, MS Views and News, all right?
OH! OH! OH!
VN! Hey, listen, everybody, seminar evaluations, please turn it in to the people standing at the door, all right? They want to get this back from you. Again, have a great night and a good end of year. Thank you.